Hello, everyone. My name is Gabriel Aceta. I'm the president of the Liga de Infectologia da Faculdade de Medicina Taubaté. I'm here with the Professor Paolo Cameli. He is a professor of pneumology in the University of Siena. And the Professor Bargagli is a professor too of the University of Siena. I made I stayed with them in December of 2019, and they accept to make this video class to us to tell what's happening in Italy, what they do with the patients with coronavirus. Professor Paolo, you have the words.
Yeah, hello everyone. Now I see that Professor Bargagli.
Yes. So sorry because I was just arriving in my room and coming back. So thank you so much for the presentation, Gabriel, and Paolo, please.
Now do I start here?
Okay. So
Elena.
just to thank Gabriel a little bit and to thank for the cooperation to your university. So it's really a great pleasure to have you. To have a contact with Brazil in this moment, also from us. So we just have a big problem with coronavirus in Italy, and particularly in the north of Italy. Although in our area in Tuscany, we have had also very big number of patients affected by interstitial pneumonia secondary to coronavirus. So I'm so proud to be part of this historical period, and also to our special unit of respiratory medicine disease, because we are a referral center for interstitial pneumonia. So we are really, involved in this kind of disease. So Paolo, if you want, I can start with my slides, okay, and then Perfect. Giving you the word, or Gabriel, if you prefer, as you want. Tell me, I can start with my presentation?
Could be, Professor.
Okay. So just few words about Siena, about our referral center. So can you see the presentation, Gabriel?
Yes.
Okay,
I can see.
Here we are. So Siena is really a wonderful town. So Gabriel has been here, and he has had the opportunity to stay in the middle of Europe, in the middle of Tuscany region. So Siena is a very small town, but is a really a fascinating place in the center of Italy. So our university is also a very old university, because you have to imagine that we started to have this kind of university very in the Middle Age, so very long time ago, and it continues to give and to achieve some of the best results from all the Italian university for its research and for its teaching. So it's a very active university, and it is involved in several fields of research. So this is our group of research. So I'm so sorry because Paolo is not in this photo, but this is our lab. And in the end of February, our lab moved from an interstitial lung disease lab to a COVID laboratory. So the same medical doctors that you can see here became immediately founded not only in interstitial lung disease, idiopathic interstitial lung disease, or secondary to different causes, but they immediately became also very active in COVID diseases. So our lab is also involved in the analysis of T lymphocytes, for example, and the immune response in patients affected by coronavirus. So we have been some of the first laboratories that were involved in the analysis of CD4 and CD8 answer during coronavirus infection. So we demonstrated very soon that patients affected by coronavirus has a significant reduction of CD4, and also the improvement of infection was associated with a great improvement in lymphocyte count. So we also are founded in biomarker research. So as you can see, we are a member of the World Association for Granulomatous Lung Diseases, as well as a big member of the ERN, European Network for Rare Diseases. So we are involved in biomarker research in interstitial lung diseases. And we also started our research for biomarkers with diagnostic and prognostic value, also in this kind of epidemia. So the total number of COVID cases in Italy has really grown up very quickly, as you can see. So starting from the middle of February, arriving until the beginning of May, so the number of patients in Italy really grew up very, very rapidly. So in March, we probably have had the most horrible moment in our history. So as you can see, the number of patients affected by, so these numbers are not, from the beginning of June, the number of patients affected from COVID, Italian patients affected from COVID-19 was really very high. You can imagine that Italy is not so populated. So also the number of deaths was really very high, and it was mainly related to the very ancient people. You can see the distribution of the patients. So that we have a 45% of patients, or 55% of female, and a 45% of male. But the male patients have a worse prognosis. They probably get most really relevant involvement of interstitial lung involvement in the lungs. So you can see the distribution of our death according to the age. So as probably the same all around the world, but we have seen a great incidence of the disease and the complication and the very severe cases, particularly in older ancient people, so people with several comorbidities, for example, patients affected by chronic lung diseases, as well as patients affected by diabetes or hypertension. So these patients developed more severe coronavirus infection. And as you can see, also patients with, patients with very severe and critical disease can also have some other diseases related with coronavirus. And we also discovered with a multidisciplinary approach to coronavirus infection and to COVID-19 disease, that the disease was not only a lung disorder, but it was a systemic disease. And this is a really relevant topic. So the distribution in Italy of the infection started from the north and maintained in the north of Italy a very high prevalence. So we cannot explain the reason of this different distribution in our geographical area. So we can imagine it. So as you can see, Tuscany and Siena is here. So it's not probably the red area of infection. So we think that, for example, in Milan, that is here in the middle of the red area, the pollution can contribute to the high distribution and the high prevalence of infection in our country. But not only pollution and environmental problems can solve the problem of a big prevalence of coronavirus in north of Italy. So we can imagine that also other factors can contribute to this different distribution of cases in Italy. For example, some people obviously discuss about the prevalence of and the distribution of the infection according also to the number of, to the population, according also to the fact that Milan is probably one of the biggest country, the biggest city in our country. But Rome, for example, has not the same distribution, has not the same number. So you can see the symptoms, the most frequent symptoms, most common symptoms observed in our patients. So we can see fever as well as dyspnea as the main symptoms in our patients, and also dry cough. Dry cough was really very common in this patient, and the diarrhea, and absolutely much less frequent hemoptysis. So the number of and the follow-up of our patients really show also in Tuscany a great prevalence in the biggest city, for example in Florence. Florence has been probably the area in which coronavirus infection reached the biggest number. Again, perhaps also the pollution can contribute to the biggest distribution of infection in this area. So this is the distribution of also the number of patients, number of cases in Tuscany during the month of March. As you can see, the peak and the biggest number has been reached during March. And now we arrived in June. And so we probably observe a significant reduction of this COVID infection in Italy and as well as in Tuscany. So the number of hospitalization really reached the same behavior. So we observed the same behavior with a great amount of hospitalized patients in March, While
Professoressa,
arriving in April, yes?
can you speak a little slowly, please?
Oh, yes, sorry. Sorry.
No
I'm
problem.
so sorry. So number of hospitalization followed the same behavior. So we have had a big peak in March, while arriving in April, at the end of April and at the beginning of May, the number of hospitalization is going down, and not easily is going down also the number of deaths that only at the end of May reached the lowest number. So we are really very proud to contribute to the research on this topic. So not only the clinical approach, but also the research approach to the study of coronavirus. So when coronavirus arrived in our country, in our city, so we create in every hospital a coronavirus disease area. So it was an area that was completely isolated from the rest of the hospital, while we continue to do in a free area, far from the COVID area, we continue to follow our interstitial lung disease patients with no coronavirus. So we continue to do lung transplantation, for example, and maintaining a great separation between medical doctors involved in coronavirus disease activities compared with some no coronavirus medical doctors that were not involved and not related with the management of the disease. So with this separation, we also perform a great team. So coronavirus disease was followed, and these patients were followed from a multidisciplinary team, not only the pneumologist or the intensive care medical doctors, but also some other kind of doctors. For example, it can be nice to know that the immunologists take part of our unit, as well as rheumatologists that play a big role, a relevant role, together with cardiologists, together with internists, so medical internal medicine doctors. So everyone takes part to the management of coronavirus disease infection. So they take care of these patients all together. So every morning we meet each other and we follow together this patient, sharing our point of view. So we had really a big opportunity to learn from each other, from the experience of the rheumatologists as well as from the intensivist doctors, because we can start together to decide the management of this patient. So you can imagine when coronavirus arrived in Italy at the end of February, no one knows exactly, for example, when it was necessary to use the steroids, when it was required to use non-invasive mechanical ventilation, when it was necessary to treat this patient with biological treatment. So we start together to learn from, for example, from China and from the north of Italy, where their data were published. We started to study and we started to obtain several information from all the other area of Italy. For example, we understand that steroids use was not absolutely to avoid or to eliminate in our protocol. We started to use the inhibitors, checkpoint inhibitors, for example, interleukin-6 inhibitors with great results in our patients. So we started to treat patients with non-intubation and non-invasive mechanical intubation, as Paolo will told us immediately after me. So we have had really a great opportunity to learn from all of us, from all different multidisciplinary approach from this infection. That was not only a lung disease, an interstitial pneumonia, but it was also a systemic disorder. So now we understand that coronavirus can give several problems, for example, because of a great inflammation associated with the infection, can induce problem in every organ or apparatus in our body. So we share our experience, for example, with the diabetologist, with immunologists, because perhaps probably in different phases of the disease, there are different phenotypes of disease. So we have patients with severe diarrhea, we have patients with anosmia, so we have patients with different symptoms, perhaps with different localization of virus. So we are really very proud because recently we published some data about the Siena population and our experience with interstitial lung interstitial pneumonia related with coronavirus disease. And so we can, for example, I can show you this study that was very recently published about the first biomarker that has been studied to define the severity of COVID-19 patients. So we have studied a special biomarker in serum from patients affected by coronavirus, separating patients in mild, moderate, and severe. So severe patients were hospitalized patients, intubated patients that require mechanical ventilation. And we observed only in this peculiar phenotype of patients requiring intubation, very high concentration of this biomarker of lung fibrosis. So we propose to this journal our preliminary results together with the cooperation of European Reference Network for Rare Disease, Respiratory Diseases, and we obtain great success. So we are continuous to analyze in different population of patients with coronavirus from different countries this biomarker that seems to be promising to define from the beginning which patients will require an intubation, which patient will have a negative prognosis compared with other. Obviously, this biomarker has to be associated with other inflammatory biomarkers, so the most common ones, for example, C-reactive proteins, or the number of leukocytes, or the dimer, and so on. And it seems to be really a very relevant result. Now I introduce Paolo, Dr. Cameli, that he works with us, and as you can see, here, this is the Association of Patients with Interstitial Lung Disease in Siena. Sorry, because Gabriel was not there for this day, but Paolo
no problem.
is the young medical doctor that works with me, and is really a very promising medical doctors directly involved in COVID-19. So thank you, Paolo, thank you, Gabriel, for the opportunity. Paolo, a te.
Okay. Any question for Professor, or I can start with the presentation?
Yes, if you still, if someone would like to make a question, so I'm here.
Quem tiver dúvida pode perguntar em português e qualquer coisa eu traduzo para a professora, não tem problema, tá, gente? Professoressa, a question. What's the, in Siena, you are doing to a second wave, if probably comes on the next winter?
Yeah. So what's a big question, Gabriel? So we don't know exactly what is going to happen in the next winter. So we are really in trouble. You have to know that also now in COVID area is open in Siena, although there is a single patient inside. So we have only one patient affected by COVID-19 in this moment in Siena, because probably it's going to finish, and that is a very nice result. But no one really would like to stop, to close the COVID area, because we really are fear the feeling that probably in autumn some other cases can appear. So we are really in trouble for this. It's really interesting, because the last of our patients is a lung transplanted patient affected by coronavirus infection. And it's really a very hard problem, because it's positive to the virus until 80 days, I suppose, 80 days. Yes. So I don't know, I really don't know.
We hope that we'll not have a second wave, but we don't believe so much, unfortunately.
And another question, what about reinfection? I know Siena is a big center of sarcoidosis in Europe.
Yeah.
And if you have numbers about the reinfection of coronavirus, if these patients with sarcoidosis have more probably to take or not?
But Gabriel, it has been really very nice to realize that we were really in trouble, you know, for our patients. You met our patients. So we have a lot of patients affected by sarcoidosis, as well as idiopathic pulmonary fibrosis, and a lot of patients affected by rheumatic disease with interstitial lung involvement. All these patients underwent immunosuppressive treatment. Okay, so they do azathioprine, they can do mycophenolate, they can do steroids, as well as methotrexate and biological treatment. So we have really fear that these patients can have the infection and can develop a very severe disease. But it's nice because we demonstrate the contrary. So the majority of our patients seems to be protected from these drugs. So when they develop coronavirus infection, they don't, in very small, in a limited percentage of patients, we have had the need of intubation. So the majority of them developed a non-invasive, a non-severe phenotype. So probably if you treat your patients with anti-inflammatory drugs, you can perhaps have a sort of protective effect. We are not alone to demonstrate this. You have to imagine that we phone to the majority of our patients during the pandemic, and we realized that only a very small number of patients were positive. So another big point is about IgG protective role. So when you have had the infection, the reinfection can occur. So IgG can really protect everyone and can give us a protection that is maintained for all life long. So that's a big question. So we don't know. We perhaps, so we are studying, for example, this last patient, this last lung transplanted patient that developed IgG, but these are non-protective IgG. So it cannot, he developed the immunoglobulin G, but cannot destroy the virus.
I understand, Professor. And one more, they asked me to hear in the private, what about the hydroxychloroquine and chloroquine? If you in Siena are using or not? What do you think about this?
We have used it because you imagine that we arrived to start to use hydroxychloroquine in the beginning of March. So at that moment, we don't have any trial discussing the utility, the real effectiveness of hydroxychloroquine in this patient. So we use it in all patients, hydroxychloroquine in the majority of them, associated, for example, with azithromycin. So we have had a large use of azithromycin together with hydroxychloroquine, and we also use the steroids. At the beginning, also high dose intravenous steroids, followed from lower dose, from a tapered dose of steroids. And the first 10 patients probably, we were really in trouble with the infective, with infective disease medical doctors, because they were really in trouble about the use of steroids in this patient. They prefer to use antiviral, antiretroviral drugs. But it seems that they were completely unuseful or not so effective as steroids. So that probably was the beginning when we start to understand that it was an inflammatory, a really big and relevant inflammatory cytokine storm associated with this kind of virus. So if you are not strong to stop inflammation, to stop this kind of inflammation, it's really a big problem. So hydroxychloroquine at that moment in Siena was used absolutely.
Understand. Thanks, Professor. And anyone here wants to do one question? Se alguém tá com, não quer falar inglês, pode perguntar em português e eu traduzo para o professor, não tem problema.
Sì, puoi dire che possono farmi domande anche in portoghese, va bene. Gabriel, posso fare una domanda io?
Sì.
May I ask you about your actual protocol for coronavirus infection in Brazil for the non-severe patients? So you use hydroxychloroquine, you use steroids, you use antiretroviral drugs. What are you using now?
Professora Estela, se ela consegue responder essa pergunta, ou a da professora Daniela, acho que é mais seguro.
Your protocol.
Sim. A professora Estela, está aqui?
Vou tentar, como uma velha epidemiologista. Repita a pergunta para ver se...
O protocolo que está usando em Taubaté para o coronavírus.
Se usate l'idrossiclorochina anche, Gabriel.
Se usa hidroxicloroquina ou não, azitromicina, esteroides ou não, professora?
Protocolo brasileiro oficial, técnico, de nós que somos médicos, não é esse uso amplo da hidroxicloroquina, até pelos efeitos colaterais profundos que pode ter Isso tem sido uma bandeira de certas áreas políticas, inclusive do presidente deste país, que é capitão do Exército, então não entende de medicina. Bom, desculpem a fala nesse sentido. Mas o uso é muito restrito, não existe um protocolo de uso de hidroxicloroquina. Tá? Logicamente, alguns locais em pacientes extremamente graves utilizaram como um recurso último, né? Não como um recurso de regra.
E il cortisone?
E o cortisol, professora?
Cortisona se usa, né? Em momentos para coibir algum processo mais profundo que possa estar existindo no sentido das inflamações deflagradas. Eu não sou uma pessoa que trabalha em hospital, então eu não tenho essa experiência pessoal. Quando eu disse eu sou uma epidemiologista velha, é a verdade. Eu sou praticante de saúde pública, mas no sentido não hospitalar. Então, a minha experiência hospitalar é absolutamente restrita, mas a gente vê usar e tem lógica o uso do corticoide segundo indicações explícitas, segundo indicações corretas.
Hello, good night. Eu vou falar em português, mais devagar. Eu sou professora da fisioterapia e estou aqui, né, tentando contribuir um pouco. Eu fico no hospital com os alunos da fisioterapia, fico na UTI, no mesmo hospital que a professora Estela, né, é responsável aí pelos alunos da medicina. Em relação ao protocolo, a professora Estela está completamente correta, né? Não existe uma determinação médica, e ela deixou bem claro isso, né, como o nosso presidente aí não é médico, mas não existe. Há uns 15 dias, há um tempo, nós tivemos uma discussão com uma equipe de São José dos Campos, uma cidade próxima, e lá eles utilizaram a hidroxicloroquina, mas não dá para fazer um estudo estatístico, né? Eles pontuaram um paciente que chegou bem grave e ventilaram, da parte de ventilação mecânica, foi uma ventilação protetora, utilizaram a hidroxicloroquina e também o corticoide, né, a cortisona, por conta de co-infecção. Então, a justificativa foi essa, né? Usa-se o corticoide, mas a justificativa nesse caso foi a co-infecção, que não deixa de ser aí, né, o quinto fenótipo que está sendo descrito principalmente em pesquisas americanas. O Marcelo Beraldo, que é um fisioterapeuta, participa dessa pesquisa para tentar descrever um quinto fenótipo, e eles relacionam bastante, né, a liberação de um pró-hormônio e a co-infecção, né? Mas respondendo, aqui no hospital, eu não estou na linha de frente no momento, retornaremos aí, a professora Estela também já sabe que retornaremos, né, professora, em breve. E aqui em Taubaté não existe um protocolo. Em São José dos Campos foi utilizado e deu certo, mas não é a recomendação da Organização Mundial de Saúde, né? E aqui em Taubaté também, principalmente na universidade, né, professora Estela, não foi desenvolvido nenhum protocolo em relação a isso, mas deu certo. A utilização deu certo.
Professora Bargagli, hai capito?
Sì, credo di sì. Thank you, Daniela, for your contribution. And the role of physiotherapists was also very important for us, for our patients. And so they arrive in our COVID area practically very soon and play a big role also in the follow-up. So immediately, also after the hospitalization, our patients going on and following the physiotherapist in their management. So we have had also now a protocol from patients that have had coronavirus infection, that they have to continue for almost 6 months physiotherapists after infection, because they can develop also consequences, interstitial disease consequence to coronavirus infection. So about the protocol, I would like to give you the work to give you the speech to Paolo, if he would like to introduce also the protocol, the Italian actually management of this patient. Perhaps Paolo can tell us.
Yes, thank you, Gabriel, for the invite to present it. Nice to see you again. Nice to meet you all from Brazil. It's a great pleasure to talk, to share with you our experience, our limited experience, because of course this is a new disease coming from December, and arrived in Italy about 28th of February, and then it strikes our healthcare system, making a lot of deaths, a lot of problem in terms of sanitary impact in our society. So I'm trying to share the screen. Okay. Just a moment. Got a problem with the connection. Can you see it?
No, Paolo.
No, okay. Yeah, just a moment. So waiting for my computer to restart. I want to ask you, because we have had an update in the management of in the general practitioner for SARS-CoV in the mild disease in Lombardy. Oh, okay. Okay, now I'll ask you later. Okay, now you can see.
Is a black. Is black to us, but are showing you are sharing, but not the slides.
Yeah. No, I think it's coming. They are coming now. Oh. Now you can see?
No.
Nothing?
Nothing.
Wait a minute.
Gabriel, se você compartilhar os slides dele, será que você consegue?
Paolo, do you want I share your slides and you tell?
Yeah. That's good. Yeah.
Only wait 2 minutes.
Yeah.
Paolo, tutto bene?
Sì, c'è un problema con lo schermo. Non riesce a... Te lo vedi, Elena?
No, Paolo Cameli è started screen sharing, ma non vedo nulla.
Ottimo.
Prova a riscaricare il file e a caricarlo un'altra volta. Eccolo. Voilà.
Yeah.
Fatto.
This is Gabriel's presentation. Okay.
Yes, it's my presentation.
You're talking. You can talk, Gabriel. Do you like?
Yes.
Would you like to talk?
Yes, I like.
Okay. This is so our little presentation regarding our experience with the COVID-19 in Italy, and particularly in our city. So the first data from China arrived only in the 24th February of 2020, when we already know that there were a case of infection in many countries, in many continents, also in America, in Africa, and Europe. And this is the first summary that was a bit very large, coming from Wuhan, in which we could see how a high percentage, a relevant percentage of patients underwent the development of a very severe disease. Just about 20% of these patients need hospital recovery, need respiratory support, need oxygen therapy because they were in acute respiratory failure. And a relevant quote of this, the 5% of population underwent a critical disease, including IRDS, acute respiratory distress symptom, also multiple organ failure, septic shock in the main percentage of this with severe infection of fungus or bacterial, going to death in a high percentage. Also, in this report, we can see that about half, more than half of patients that underwent to intubation or tracheal intubation go to exitus, and so telling us about the high lethality of this virus infection, also in patients that manage to arrive to the best, to the higher intensity, to the highest intensity of cure in China. The next slide, Gabriel. Can you go ahead? Okay. So this is real. We really understand since the beginning of 2020 that before that coronavirus arrived in Italy, that this could be a very important menace for our life, for our work, as it was very fast in spreading in the countries, in the cities, in the population, treacherous because the clinical impact, the clinical symptoms could be really tricky. Maybe patients that seems to be very fit after an hour, after 2 hours of oxygen therapy, underwent a rapid deterioration of their conditions, leading to acute respiratory failure and then to the need of intubation, and potentially fatal, as we have already said in the precedent slide. So you can see that we can schematic the population that was affected by SARS-CoV-2 with a sort of paradigm in which we can find at the base the great majority of these patients in which develop mild symptoms or were asymptomatic, but they could also perform a viral shedding, and so they can contagiate all the other person, all other people, especially older people, their parents, their relatives, leading to a high burden of this disease in the population, and then coming up on the parameter that arrive to a more severe clinical impact and coming to the exitus. The next slide. Can we go ahead? Okay. And also what we see when, or what we saw when the patient arrived in hospital, because of course patients that they are coming, that are recovered, are of course the most severe patients, the most severe cases. We can see that the tricky nature of this virus, in which in the first week, in the first days after infection, patients didn't report such important symptoms, and from the second week, from the 7th, 8th, and 10th day of disease, they can develop respiratory failure, they can develop respiratory distress, and also they can develop a systemic syndrome, including the impact, the infection of other organs, such as the central nervous system, or also the heart, also the abdominal organs, and also regarding the vessels, leading also in some cases also to a systemic coagulopathy and an excessive risk of coagulation, of prothrombotic status, but also of hemorrhagic findings. The next slide, Gabriel. Yeah, thank you. So this is the timeline that has been proposed for COVID-19, that is the syndrome regarding the pulmonary symptoms in patients affected by SARS-CoV-2. So the first phase, the infection, so the virus arrives through the droplets in our airways, in the nose, in the pharynx, and then going down to arrive to affect pneumocytes that are, of course, the epithelial cells of alveoli present in our respiratory system. and so developing some systemic disease, some systemic symptoms like fever, like dyspnea, and for the first time, the evidence of an imaging data coming from lung ultrasound echography, in which we can find for the first time the first sign, also before the chest X-ray, the B lines that are coming, especially in the lower lobes. Then after that, the person can go to resolution of symptom, resolution of viral infection, or may develop a more severe disease leading to a diffuse alveolar damage in our alveola, in our lung parenchyma, leading to hypoxemia, and then also to acute respiratory failure. And in that case, we have the correlation with the imaging of lung ecography, in which we can find that the B lines come to coalescent altogether, form consolidations, and then arrive to the next phase with the development of a cytokine storm, and particularly interleukin 6, interleukin 1, interleukin 4, and also regarding all the pathways regarding activated by JAK-STAT tyroskinases, leading to a sepsis, so to a systemic infection and to a possible multiple organ failure, and for the need of advanced hemodynamical and also respiratory support, and till to arrive to the oral tracker intubation. At last, we can find the last step of this timeline is the development of septic shock of RRDS that show, of course, as we know, the highest lethality, and that was a sort of a failure of our kind of assistance, in fact, because our objective of all medical doctors was not to elevate to RADS to septic shock. The next slide. So as you can see, SARS-CoV-2 can affect practically all our organs, all our parenchyma. Here we can see in this work that was published on the Lancet how the infection and the immunological response by lymphocyte mononucleate cells can infiltrate the parenchyma of lungs, but also you can see on the left the infection of the liver, so hepatotoxicity, as we can see in a great percentage of our patients, in which there are a great increase of transaminases and also of hepatobiliary biomarkers, and also regarding the heart tissue, and so leading also to a potential interstitial disease of heart, leading to potential ventricular arrhythmia and to sudden death. The next. And also that was very, very important, and that leads also to a change in the paradigm of treatment of these patients, the presence of disseminated thrombus in the little vessels, especially in the lungs, but also we have found it also in the systemic circulation, and that leads to the development of the use to the insertion in the therapeutical management of heparin at anticoagulation doses. That was also proved, as you can see, I would say you that in the management of patients that were out of hospital. The next. So the mission of pulmonologists in COVID-19 was to stay awake, to stay sharp, to stay focused on these patients, to help our patient to breathe, and also to provide them all the oxygen they need. In fact, we have learned in these weeks that the best respiratory support lies where you can dedicate your full skills, because the patients, you can follow your patient in the right way only if you have the time, or if you have the tools to help your patient to ameliorate their symptoms. And this leads us also to reevaluate and to criticize the data that were coming from China, from other countries, in which they were talking to us that non-invasive ventilation could be detrimental in these patients. And the same way, the high flow nasal cannula was, of course, was not well considered because it was not considered to be useful in these patients, and that may delay with devastating effects the orotracheal intubation. But in reality, we have found a great utility on these tools for the support of oxygen in these patients. And also, the most important thing is the importance, the key role played by a multidisciplinary approach as the collaboration with other specialists, such as intensive care general doctors, but also cardiologists, infective disease medical doctors, rheumatologists, and also internists, internal medicine doctor, helped us to make an accurate selection of patients to report to orotracheal intubation to the ICU. Also, the importance of the alliance between pulmonologists and cardiologists in the middle and intensive care of these patients, to find the balance in those patients that were not so severe to need an orotracheal intubation, but at the same way they were not so mild to not require a personalized support from a respiratory and cardiovascular point of view. And of course, the use of techniques to mix some techniques that are traditionally incompatible, such as pronation and non-invasive ventilation with helmet. The next slide. So, of course, another important aspect is that COVID-19, especially in the most severe disease, has been a common to acute respiratory distress symptoms. This is true for some aspects because, of course, there is a very specific interest, a tropism for the virus, for the respiratory system. Also because the imaging data, especially the CT scan, and the histopathological features were very, very similar according to the literature on this issue. Regarding also the strategy, the approach for the mechanical ventilation, in which a protective lung strategy must be preferred in this patient in order to avoid really the ventilator-induced lung injury, and also for the utility of pronation in the most severe case of hypoxemia. However, there are a lot of difference, clinical difference, but also pathophysiological difference that prompt us to consider COVID-19 as a different clinical entity in respect of the classical RRDS. Like the time of onset, as you can see in the timeline of COVID-19, the most severe symptoms occur after 10 days, 12 days of the start of the infection, while RRDS, by definition, ensure an interval of about 7 days between the start, the cause of the pathology and the onset of RRDS. Importance also the discrepancy of clinical symptoms if compared with the organ function that we can see in blood gas analysis, as which we can find a lot of patients that were not so dyspnoic, were not so tachypneic, but they find the hemogas analysis, arterial blood gas analysis, very, very important, very, very severe hypoxemia in these patients. And also the fact that the patient with COVID-19 showed some lungs that were easy to ventilate, as it doesn't happen in RRDS. And also the steroids. We know that steroids are not absolutely useful, are not indicated in RRDS, but in our personal experience and also in other Italian centers, steroids was very, very useful in reducing the inflammatory burden, the cytokine storm in the lungs, and so to avoid for many, many patients to go to the orotracheal intubation. The next slide. So the organization, of course, saved lives, because the organization not only regarding the clinical aspects, the clinical resource to give to this patient, but also for the dislocation of these patients inside in this little world of the hospital. So of course, we need to separate completely the personnel, the nurse, medical doctors, and the patients in a different area that was completely isolated from the rest of hospital, especially for ICU, in which of course there are also a major risk of developing a severe infection from polyresistant, multi-drug resistant bacteria. Of course, the importance also of some structure of such buildings, such as the pressure negative rooms that in our hospital were only in the infectious disease department, and so were need to rebuild, of course, in the COVID unit. And so the importance of the collaboration, of the briefing, of course, the possibility to talk, to share our experience with our colleagues, and to create also a fluid and multidisciplinary works in order to fight each other near each one other with the patient. And also the importance also to evaluate, and this is very important from a social point of view, of the healthcare settings and the hospices, which unfortunately we have found in Italy has been a very, very devastating effect on the elderly population that is potential social sanitary bomb, so need to be re-isolated, to be protected, and to be protected from the infection. The next. So our goals, what are our goals as pulmonologists in the COVID-19 disease? First of all, sustain the oxygenation, no matter how, no matter low flow oxygen, high flow nasal cannula, CPAP, no matter what, you have to maintain the oxygenation of these patients. And of course, you have to be very, very smart and very, very careful regarding the non-invasive ventilation, and also with the high flow nasal cannula, but also with the rebreather mask or the venturi mask that may spread the virus in the room of the patient. So you have very, very protected when you go near to these patients. The alveolar recruitment, that is very, very important, and so the importance of CPAP and the PEEP, the positive and the expiratory pressure, to help to improve the oxygenation and to recover a bit of lung to be to return for the normal function. And of course, to increase the compliance. So try always, also with the physiotherapist, to recover major compliance of our lung disorder in order to reduce the work of breathing, in order to reduce the respiratory rate, and so to give our patient the time, give our therapies the time to start to be effective and to ameliorate the condition of these patients. The next one. So regarding non-invasive ventilation, our preferred way to the interface for this kind of treatment was CPAP, the use of helmet, because of course you all know that it's really easy to wear, to manage, also for the nurses. Is better tolerated in respect with oral nasal mask, except for the noise, because it can be very, very noisy for the high flows that requires this kind of non-invasive ventilation. It is good for pronation. Yeah, we find it that in about 10-15 patients, we use this double technique in order to try to avoid this patient to go for the intubation, and it was good. It was very, very functional, and of course it provides less headaches in respect with the other interface. However, we have also to underline that always for the entrance tube and the exit tube, we have to put the antibacterial and antiviral filters of high quality that are certified with 99.999% against virus and against bacteria coming from the ventilator and from the helmet. And of course, you have to pay attention that the removal of the helmet is a high risk procedure for the spreading of virus in the room. And so you have to be really, really focused and coordinated with your nurses, with your colleagues, in order to stop the ventilation and remove very, very quickly and very, very coordinated the helmet from the patient. Again. Go ahead. Okay. No. Come back. Yes, and this was demonstrated just about 5 years ago when you remember the SARS infection, the SARS epidemic in the 2003, always in the Southeast, in which these problems of the spreading of a virus was underlined during that epidemic area, and this is a study that found that, of course, the helmet, if well known, well positioned, can minimize at about 20 centimeters the risk of the shedding or the spreading of viral for the personal sanitaire, for the medical doctors, and for the nurses. And another tips that is very important to avoid the arm straps, because there was a risk of thrombosis in this patient of the arm, of the venous system of the arm. And we found, in fact, in patient that has made CPAP, 2 cases in our population, in about 70-80 patients, 2 cases of thrombosis of venous thrombosis of the arm. The next one, Gabriel. Okay, so our experience, in conclusion, the importance, the most important thing is to careful monitoring our patient in their respiratory function, symptoms, and signs, in particular regarding the breath dynamics. For example, abdominal and paradoxical breath is a very, very bad sign for the prognosis, and leads in the majority of cases to the intubation. To assess the respiratory rate, the alveolar concentration, the alveolar pressure of carbon dioxide, and the P on F ratio, that are very, very important also to assess the response, the positive response to the CPAP in these patients. Of course, the bedside imaging, that was very, very important also, because helped us not to contaminate other departments of our hospital, such as the radiology department, with the CT that was dedicated only in the most severe patient. And also, of course, to underline again and again the importance of to be very, very careful on the patient, especially on those patients that were on NIV therapy, because those were to be monitored every hour to evaluate their blood gas analysis, because, of course, non-invasive ventilation can be very, very useful, but could be very, very detrimental, especially if you are not following your patient, if you are not early catching the signs of deterioration of this patient. In the following our routes, we have seen also that only 9 patients has been intubated in our center. That was just the 10% in a relatively small cohort of our patients. So that was a very good results, and leading us also to a very low mortality in our population. So regarding take-home messages, of course, another appeal to stay together, because the importance of multidisciplinary in COVID times is absolutely vital, is absolutely important, and help us to save lives, to give the best assistance to our patients. Of course, we need scientific evidences. We have demonstrated that non-invasive ventilation is not the devil, and of course, steroids that were demonized at the beginning of this infection, in reality shows is good old properties to help us to manage the acute respiratory failure. And so, of course, this is to underline how we really need very solid data, and when we cannot follow every study, every data that's coming from published literature, that can be very, very counterintuitive. And also the importance to know and to use all our potential tools that we can use to support our patient, because of course you cannot use what you don't know. Okay, I finished. Hope you appreciate.
Yes, Professor, I have a question.
Yeah, I'm Gabriel. I'm not professor.
Ah.
Until now.
Dottore.
Yeah.
Dottore, I think many of here have many students on the first year and the sixth year for medicine. What we can do to help the doctors in ECU in this case to COVID-19. In Taubaté, the sixth year helps to in the front of line, but in many cases, what you are telling to your students to do in this case?
In our students, for
Yes.
our students. Yeah, I have to admit that when I was working in the COVID unit, I never see also my parents, my relatives, so I don't see also any student. But of course, now that I'm out from a COVID unit, that's very important to make understand the importance of prophylactic measures, to be very, very aware of the importance, to be very, very careful on the reduction of the spread, and also, of course, maybe it's also an opportunity to improve our also teaching and also the way to learn to our new medical techniques, also because the telemedicine is coming to be very, very important in the next years of medicine, also too because of course for the increasing of chronic disease, we will have always a great request of medical science also at home of these patients. So maybe this could be an opportunity to improve this kind, also to teach our students.
Perfect. And Professor, one more question they asking here. In Spain, some doctors adopt a protocol of pulse therapy using corticoids. If in Italy, this happens too.
I think that some students are, some centers are doing this experimentation with the use of steroids. Unfortunately, in our center, we have had we had the impression that steroids could be really, really very useful. But we use also, in order to potentiate the anti-inflammatory properties of many rheumatological drugs, such as anti-interleukin 6 or anti-JAK. And so our data is not so clear. We are not able till now to evaluate in the right way the effect of steroid treatment in our population.
Got it. Anyone else wants to do other question?
A question, please.
Okay.
My name is Jose. I'm doctor from control. I'm in the hospital of Cameli in São Paulo. About the use of heparin and clexane in thrombosis in the use in Italy or not?
Yes, in our patients we used at least prophylactic enoxaparin, but in about 40%, and maybe in all our patients that were recovered in the ICU and also in UTIR unit. We use also in the majority of cases anticoagulation with therapeutic doses, with enoxaparin and also unfractionated heparin and also fondaparinux. This is because we find in our patients, especially in the most severe patients, the evidence of coagulopathy, the evidence of disseminated thrombosis and the activation of coagulation system. And in some patients, we also underwent to the infusion of plasma because of the evidence of clinical and laboratory findings of disseminated intravascular coagulation.
Thanks.
So we definitely think that enoxaparin could be useful, and I think that in Lombardy, where the region of Milan, all general practitioners were advised to use enoxaparin also in outpatient.
Thanks.
My pleasure.
Mais alguém quer perguntar, gente? Não precisam ter vergonha, qualquer coisa a gente traduz. Alguém, por favor, desliguem o som, gente, por favor, quem está com o som aberto. Well, I think it's this professor, Dr. Paolo, Professor Elena. Let's pick my... I need to thank you so much to this class. Was a pleasure to me to receive you in Brazil. I don't know it's only video, but you helped us a lot, showing us what's happening in Italy, what you do to helping us. We are now passing to a difficult time, and I think this to the students here in Brazil give us a lot of information. Grazie.
Thanks to you, Gabriel. Thanks to your university. So the tip of our university will show this cooperation also in our at our university. So he just wrote me that he wants to publish this relation, this kind of very useful relationship that we are now starting to have with Brazil. So we are really very happy to have had you in Siena, and I would like to continue this cooperation with your university, also for PhD students, and when hoping that the coronavirus will be disappeared, we hope very soon, so we can do something also for improving the relationship between your university and our university, also for students that would like to come in Siena to have a research opportunity and also to study interstitial lung disease. So thank you so much, Gabriel. Thanks a lot to your to Stella, to Daniela, to everyone. So hoping to see you in Italy, hoping to see you in Siena, probably in the best moment.
For sure.
Okay.
Professoressa and Paolo, grazie per tutti.
Grazie a voi, grazie davvero. E buona fortuna. And take care of you and of your students. Okay?
Ti aspetto in Taubaté.
Adorei o buona fortuna. Buona fortuna.
Grazie. State bene.
Muitíssimo
ciao.
obrigado. Grazie.
Ciao.
Buonanotte.
Buonanotte.
Buonanotte. Ciao.
Para os alunos, o forms foi disponibilizado aqui nas mensagens. E a palavra-chave é quarentena, tá bom? O certificado será feito pela Unital. E, bom, é isso. Obrigado por todos que estiverem presentes conosco. Obrigado pela professora Estela, professora Daniela, pela Unital por ter disponibilizado para a gente o Zoom. Por todos presentes no domingo. Bom, esperamos a próxima palestra. Muito obrigado, gente.
Eu agradeço também, né? Agradeço a professora Virgínia, que ficou conosco, nos apoiando, a professora Daniela, a dedicação do Gabriel e da Beatriz, em nome deles, eu cumprimento de coração toda a Liga. Tá?
Muito obrigado, professora.
Estou muito feliz de ter participado nessa ocasião.
Eu que agradeço.
Obrigada,
Bom, é isso, gente.
Gabriel. Tchau, professora Estela. Tchau, professora Virgínia. Bom final de domingo. Um abraço.
Gente, parabéns, viu? Pela organização. Parabéns. Tchau.
Abraço a todos.
Tchau.
Tchau, tchau.
Tchau.
Então, perdi.